The first presenter of the session is Dr. Anuja Patil. Start.
First contact investigation in patients with uveitis. So as we all know, uveitis is not a single entity. It comprises of anterior, intermediate, posterior and pan-uveitis and is responsible for approximately 10% of worldwide blindness. The diagnostic workup of uveitis is challenging because of wide range of differential diagnosis, and therefore a tailored approach to the laboratory investigation is the gold standard. So keeping that in mind, we aimed to determine the pattern of investigation in uveitis patients undertaken at first contact, and to categorize these investigations into either tailored or not tailored investigations, and also to determine whether there is any added benefit provided by the investigations versus additional financial burden to the patients. So it was an observational study conducted over a period of 18 months. All consecutive uveitis patients referred to a center were included, with a minimal of 200 uveitis patient as a sample size. We included all age group with a primary diagnosis of uveitis managed initially elsewhere other than our center. The exclusion criteria was those which presented for the first time to our center and uveitis as a secondary complication. So those patients which presented to our center we took a brief history and examination. We reviewed all the records and investigations, and then based on this standard targeted approach investigation, we categorized it into tailored and not tailored. Approximate amount of investigations was obtained from the patients. So 201 patients were included with a mean age of 35.35 plus minus 14 years. And there was a slight male preponderance. So these were the commonly done investigations in our patients. That was chest X-ray, CBC, Monto and ESR test, which was done in more than 70% of patients. And we could find that around 57.2% patients had investigations done which were not tailored. Also, we could see that the approximate cost in the not tailored investigation group was 3 times higher than that of the tailored investigations, which added to the financial burden to the patient. So as we've seen that these were the commonly done investigations, and we in literature found that the relevance of ESR and CRP in active uveitis patient, which was most of the time normal in active uveitis patient, mostly because it was an idiopathic in origin. But if it was raised, it pointed out towards a systemic involvement. Also, in another paper, it was mentioned that lymphopenia associated with increased ACE contributed more towards sarcoidosis as the diagnosis of uveitis, as opposed to individual investigations. Also, in another study, chest X-ray was found to be abnormal in 15% of patients with active uveitis, and therefore we could say that it is less reliable, and we can therefore plan for a more specific and sensitive test like HRCT chest. This was a study conducted in another Apex Institute, wherein the criteria for uveitis associated with TB was strong bond to positive quantiferon and PCR test. It was found that the quantiferon TB gold test was banned by WHO and because of high positivity rate in endemic countries, and therefore it should not be advised to the patients. We found that the mean cost of the investigations in the not tailored group was 3 times higher. A similar thing was observed in another study, which was ULISSE study, wherein the mean cost per patient in the standardized group was lower as compared to the mean cost per patient in the open strategy. So to conclude, not all investigations were tailored. It added to the financial burden and contributed less towards the diagnosis. So always think before diagnosing the investigations and follow a tailored approach. Thank you.
Thank you very much. Thanks for finishing on time.
Yeah. So in how many, if just as an interest, I want to know how many patients were advised HRCT? Like nowadays, a lot of patients are shifting. Did you look at that?
HRCT was advised in 13 patients, ma'am. It was 6.5% patients.
Okay. And did you also look at the yield of these tests, that how many of these tests were positive?
Yes, ma'am. Ma'am, systemic like investigations had contributed to the diagnosis in around 17.8% patients.
Mm-hmm. That's all.
Yes.
Investigations, what is the results of HLA testing?
HLA testing was done in a very less amount, sir. It was done in around 8% patients, and it was not contribute. Most of the time, it was negative.
Okay, thank you.
You mentioned about lymphopenia.
Yes,
Can
sir.
you define lymphopenia?
So lymphopenia is decrease in the lymphocytic.
Decrease we know, but what is the cutoff value for lymphopenia?
Sir, it is. So I do
That's
not
part
know.
of your study, right?
Yes, yes,
So-
that's true. I'll read about it, sir. I do not know about it.
Okay. So what was the goal of doing this study? Why did you want to do this study?
Sir, it was to find out, like most of us, we advise investigations based, it is a standard protocol that we advise all the investigations in all the uveitis patients. So most of these investigations, they are not tailored as per the presentation of the patient. So we wanted to find out that how prevalent it is, like how frequent we tend to do that.
Okay. And did you read up the ULIS study that you mentioned? Have you read
I
up that
did
paper?
read. Yeah, I read it up, sir. It was basically a randomized control trial. It is the only RCT, I think, which is comparing the standardized strategy versus the open strategy, wherein they had seen whether they have basically randomized the uveitis patients into two categories, wherein in standardized strategy a tailored approach was used, and in open strategy they had there was no tailored approach used. They basically advised whatever they wanted to advise, and then they basically also calculated the cost aspect of, like, economic aspect of
Thank you.
that.
Thank you very much.
Thank you, sir.
Till the next week.
So our next speaker is Dr. Tudimol Devasya, who will be talking on the role of intravitreal ganciclovir therapy in cytomegalovirus retinitis.
Good morning all. Today I'll be talking about role of intravitreal ganciclovir therapy in cytomegalovirus retinitis. CMV retinitis is a frequent cause of opportunistic ocular infection in immunocompromised individuals, progressing to blindness in the absence of early intervention. With the development of potent antiretroviral chemotherapeutic agents, there is decrease in the incidence of CMV retinitis, decrease in the viral load, improvement in CD4 T cell counts, and reduced mortality. And the four medications approved by the FDA for the treatment of CMV retinitis are ganciclovir, valganciclovir, cidofovir, and foscarnet. And all these agents are virostatic. In our study is a non-randomized retrospective interventional series consisting of a consecutive cohort of 7 ISO 5 patients with CMV retinitis who received intravitreal injection of ganciclovir on a bi-weekly basis for 3 weeks as induction regimen, followed by oral valganciclovir and heart therapy. This is our first patient who presented with the indolent SON1 CMV retinitis with a vision of 660, and her left eye was PL negative with a chronic RD. After 6 doses of intravitreal ganciclovir, we can see that there's a good resolution of lesion, and she was put on maintenance therapy. But there was poor compliance with the oral medication, and there was reactivation and retinal detachment, and she underwent vitrectomy and silicone oil tamponade. 3 months after vitrectomy, we can see there is a well-attached retina and good resolution of lesions. And this is a patient number 2 who presented with both eyes SON1 CMV retinitis. And this patient also received 6 doses of intravitreal ganciclovir, and we can see good resolution of lesions. Totally, we gave 40 injections, and all the patients did good in the induction phase. And one eye developed reactivation and recombinous retinal detachment during maintenance phase because of poor compliance and needed vitrectomy. Though all the patients stabilized, there was decreased final visual acuity because of the retinal atrophy in the healing phase. Ganciclovir is a virostatic drug which interferes with the DNA polymerase, resulting in inhibition of viral replication. FDA-approved routes of administration are intravenous ganciclovir and intraocular implants. These routes are expensive and may not be appropriate for low or middle-income countries. Intravitreal injection of ganciclovir is easy, safe, and cost-effective, and provides fast and high intraocular drug concentrations. The reported dose ranges from 0.2 to 6 milligram. It is typically used for zone 1 CMV retinitis as induction regimen of twice weekly injections followed by maintenance regimen of oral or intravitreal ganciclovir. In this case series, a total of 40 injections were given in induction regimen with a good resolution of CMV retinitis. There was no case of endophthalmitis. On follow-up, one patient developed reactivation and retinal detachment due to poor compliance with the oral medication. Though there was disease stabilization, there was decrease in visual acuity secondary to macular atrophy in healing phase. To conclude, intravitreal ganciclovir in the maintenance phase has the advantage of being cost-effective, targeted to eye with minimal systemic side effects, rapid and longer acting, thus increasing patient compliance. And there is need to explore intravitreal therapy as means of sustainable maintenance regimen, especially in developing countries where cost-effective treatment is the need of the hour. Thank you.
What was the dose that you used in your study?
2 milligram and 0.1 ml, ma'am.
2 milligram. And how do you decide the end point? When do you stop giving the injections? Did you follow a set regime like you just gave 6?
The induction phase, bi-weekly injections for 3 weeks, ma'am, followed by in the maintenance phase, weekly 1 injections. Mm-hmm. And when to stop therapy is when the disease is stable without any activity, and the patient, if the immunocompromised patient should be on heart therapy and CD4 count more than 150. Yeah. And this should maintain for 3 to 6 months.
So in that patient who had reactivation, do you think giving more injections would have prevented?
The thing is, this group of patients did not receive injection ganciclovir in the maintenance phase. We gave oral valganciclovir, which is very costly. And these patients, because they come from a poor background, they don't take the tablets and they have a recurrence, reactivation. Now we have a group of patients who are receiving maintenance dose of injection only, not oral valganciclovir, and they are sticking to it and they are having good remission.
These 2 cases you showed, both are HIV positive?
Yes, all of them are HIV positive patients.
And you said 40?
So we all know that SLE is a chronic multisystem autoimmune inflammatory disease, and pediatric SLE is a rare disease which presents prior to 18 years of age. Pediatric SLE represents approximately 10% of SLE cases with an incidence of 0.3 to 0.9 per 100,000 children years. A 9-year-old girl presented with both eyes decrease in vision with pain and redness for the past 15 days with fatigue, anorexia, fever and arthralgia. And she had a butterfly rash with diffuse erythematous non-pruritic rash over the malar region, chest, abdomen, back, palms for the past 1 month. This is what the fundus picture looked like. There was extensive changes in the retina with disc hyperemia, CME, and peripapillary areas of graying with extensive perivascular sheathing. This is what the OCT showed with this CME, gross CME with a neurosensory detachment and a bacillary layer detachment. Prior lab investigations, there was microcytic hypochromic anemia with leukopenia. A differential diagnosis at this time of leukemic, anemic, lupus retinopathy was made. These were the systemic investigations which we did. Serum ANA was positive. ENA antibodies were strongly positive. And serum complement was low. Rheumatoid factor and anti-double-stranded DNA antibody was negative. Our patient fulfilled the diagnostic criteria laid down by EULAR or ACR with positive ANA as entry criterion and a high total score of 20 for the clinical and immunological criteria. Patient underwent, she was diagnosed as retinal vasculopathy secondary to pediatric SLE and juvenile dermatomyositis, a kind of an overlap syndrome. She was given 3 doses of pulse IVMP, oral prednisolone 10 milligrams twice daily, followed by oral HCQS 100 milligram once daily. Subsequently, she was managed with IV cyclophosphamide, 6 consecutive monthly doses, and oral azathioprine. CBC, LFT, KFT were monitored monthly. They were within normal limits. For the eye condition, she also received topical steroids. So this is the 6-month follow-up visit. There was both eyes disc pallor noted with complete resolution of CME and subretinal graying, cotton wool spots and perivascular sheathing had all regressed. And you can see in the angio, which is courtesy Dr. Diksha Katoch at PGI, that there was the disc was hot, but there were capillary non-perfusion areas more so in the left eye and the periphery, and she underwent a laser photocoagulation to those areas in the left eye. At the latest follow-up at 1 year, vision is 6.6 OD and 660 OS, and she's continued on tab azathioprine, tab HCQS, and tab prednisolone. And this is what the fundus picture looks like. You can see the lasers here in the periphery in the left eye, and there's no CME in either of the eyes. So pediatric SLE has a less pronounced female to male ratio, higher frequency of renal, hematological and neuropsychiatric involvement, higher disease activity, more organ damage and worse outcomes. SLIC criteria had greater sensitivity than the ACR criteria for pediatric SLE. Lupus retinopathy is essentially an immune complex mediated vasculitis, or it can also be due to hypertension induced nephropathy. Retinal microangiopathy, vasculitis and severe vasoocclusion are seen. Also choroidopathy is also seen. Treatment of ocular manifestations is with systemic immunosuppression in the form of HCQS, systemic corticosteroids, azathioprine, cyclophosphamide, methotrexate, mycophenolate mofetil, and biologics. Local therapy in the form of laser photocoagulation and anti-VEGF injections, and finally vitrectomy have been described. So ophthalmic features are not a part of formal diagnostic criteria of SLE, and there's a discrepancy regarding which, if any at all, ophthalmic findings are included in disease activity scoring systems for SLE. Retinal involvement essential clues to disease activity due to the direct visualization of vascular phenomenon, and active lupus retinopathy is known to portend systemic flare-ups, and a multidisciplinary team approach with a pediatrician, rheumatologist, and ophthalmologist are required to provide optimum patient care. Thank you.
Thank you. I think we'll skip the questions and we'll move on to the next one.
Thank you.
Next speaker is Dr. Adul Tadani.
My topic of today's talk is role of interferon alpha therapy in BDM case. So this is a patient of 75 years old Asian male which presented with the symptom of blurring of vision since 2 to 3 weeks. He is known case of metastatic lung carcinoma which was detected in August 2021. So brief intro about that patient. He had undergone lung biopsy followed by 1 cycle of chemotherapy, and after genetic mutation analysis he had PD1 testing score positive and EGFR negative, for which he had undergone 4 cycles of immunotherapy with pembrolizumab, and at the end of the cycle, after 10 days he developed blurring of vision at the end of 4th cycle. So on fundus examination, patient had multiple neurosensory detachments and multiple pigmentary clumps which was seen. On OCT and FAF was done. OCT showed localized serous elevations temporal to the macula and with few choroidal folds, with pronounced RPE abnormalities which were seen in FAF with scattered hyperreflective spots. On fundus fluorescent angiography, there were multiple mottled hypo with hyper fluorescent spots which were seen. These with fundus findings like multiple orange red geographical patches which are seen in giraffe skin pattern, along with confocal findings which were pigment clumps which were seen, and FAF findings and OCT findings, along with ACTAP which was done in this patient with pigmented melanocytic cells which were found. BDM was confirmed. So on treatment, we stopped the immunotherapy and continued the chemotherapy along with the steroid, systemic and oral steroids with anti-glaucoma medications which was there. And for the SRF, we used one trial of anti-VEGF in both the eyes, but no response was seen. So patient was started on interferon alpha therapy, which was given after the ethical committee approval. So on OCT comparison from after 4 weeks of this interferon alpha therapy, the SRF was completely resolved and the swelling was completely gone. So cytokine biomarker analysis of this patient also showed the decrease in MMP9 levels and IL-1 beta, ICAM, and IL-17A and TNF alpha levels. But at the end of the treatment, VEGF level was again increased. So on discussion, there were multiple treatment modalities which were available and which were used, but with variable results. So like in Rahimi et al., they used ocular radiations, SRF drainage, and corticosteroids. Plasma pheresis has also been used in some patients with variable results. BDM is a hallmark of grave systemic disease, so requires high suspicion and prompt evaluation is required. Complete resolution was seen in our patient after interferon alpha therapy with after 4 weeks of usage, and resolution in MMP9, IL1 beta, ICAM, and IL-17A and TNF alpha was also seen. So because this was best to our knowledge, there was no case reported with interferon alpha in this refractive edema in this BDM patient. So we presented this. Thank you.
Thank you. Great presentation. You want?
What is the literature on this? You said there are no cases at all. So how did you think of
no
giving-
literature on usage of interferon alpha. So we think it can be used in this cases, but because the mortality rate is very high, the poor survival rate is there. So their patient do not reach that. Some patients usually don't come for this also. So sometimes the patient was actually stable overall physically. That's why he was coming for the follow-ups. Otherwise, usually patient don't come for this also. So it's
Any
very
other biologicals, Humira, adalimumab, any study on that?
no.
Today I'll be presenting treatment outcomes of epidemic retinitis, doxycycline or steroids first, a quantitative OCT angiography based study. Epidemic retinitis or post-fever retinitis is characterized by acute onset multifocal retinal infiltrates following a flu-like prodrome. Rickettsiosis is a common cause, but due to non-availability of confirmatory tests, steroids are often used as initial empirical treatment. We study the flow deficit in the superficial capillary plexus following clinical resolution of retinitis using SSOCTA with ImageJ software. We compare the macular ischemia in patients who received doxycycline first versus steroids as the initial treatment. This is a retrospective study. The diagnosis was based on presence of retinitis, recent history of high-grade fever, and a positive Weil-Felix test. Those who did not have a follow-up SSOCTA were excluded. 17 eyes of 11 patients were included. 11 eyes of 8 patients were treatment naive and belonged to the doxycycline group or group 1. 6 eyes of 3 patients had already received oral and or local steroids prior to presentation and belonged to steroid group or group 2. All patients received doxycycline 100 mg BD for 3 weeks. Best corrected visual acuity, central foveal thickness, and percentage area of ischemia were compared. ImageJ software was used to obtain the percentage area of flow deficit in the 4.5 mm OCTA scan of the superficial capillary plexus. So this is the method that we used. We opened the image in the ImageJ software, converted it to 8-bit, used the threshold function to delineate the area of ischemia, and the percentage of ischemia was obtained. Best corrected visual acuity improved significantly in both the groups. Central foveal thickness decreased, but it was not significant in group 2. This is the diagram showing a comparison of ischemia in the doxycycline and the steroid group. So the first panel is the clinical photo. Second panel is the OCTA following resolution of retinitis. And the third panel shows the threshold function applied. This showed that the percentage area of ischemia was 3.5 times more in the steroid group compared to the doxycycline group. Case example from group 1. So you see at presentation multifocal retinal infiltrates. Following healing, there are areas of flow void that co-localize with the initial areas of retinal infiltrates. The characteristic maculopapular rash has healed following treatment. This is a case in group 2, 24-year-old male who received posterior subclinic triamcinolone followed by dexamethasone implant prior to presentation, and there is dramatic improvement in visual acuity as well as ischemia following treatment with doxycycline. The limitations of this study: this is a retrospective design, but this is the first study to objectively quantify retinal ischemia following resolution of epidemic retinitis with doxycycline and steroid treatment arms. Group 2 was treated with steroids before presentation. Therefore, SSOCTA was done after about 7 weeks from onset in group 1 and about 20 weeks from onset in group 2. However, there was significant improvement in BCVA after initiation of doxycycline. The sample size was small, but it compares the outcomes in patients who received only steroids versus early doxycycline. Therefore, steroids should not be instituted as an empirical treatment in these cases. Doxycycline results in far lesser ischemia, better visual prognosis, and quicker recovery. OCTA is a useful modality to monitor retinal ischemia and evaluate treatment outcomes. Thank you.
Thank you. Finishing on time. So my question is, how did you ensure, this was a retrospective study of course, but how did you ensure that both groups were comparable? the degree of retinitis between both groups was comparable? That's question one. The second is, when you do a prospective study in future, would you consider one arm where no treatment is given? Because
Yes.
the spontaneous
Yes.
course of the disease
Yes.
also results in resolution. So we don't
Yes.
know. I mean, consider a situation where the steroid arm was probably the worst arm, okay, more retinitis than the doxycycline group. Then it's natural that when they resolve spontaneously, the doxy would have appeared to do better than steroids.
Yes, sir. So thank you for the questions. The first part, whether the retinitis lesions were comparable. Sir, if you see, if I can go back to
I
the...
was looking at that picture,
Yeah, so if we go back to this picture, if you see, we have some very severe cases in group 1 and severe cases in group 2. So the number of retinitis patches range from 5 to 20. And although the sample size is small, the number of retinitis lesions were comparable. The second part of the question, yes, if I do a prospective study, we can also see the patients who did not receive any treatment. But as of now, I have not included in this particular study, but patients who do not receive any study also have significant ischemia. And
good morning, everyone. I'll be presenting about paradoxical worsening of intraocular inflammation in patients with syphilis. As we know, syphilis is a sexually transmitted disease. It can be present in the body as a chronic systemic infection caused by the spirochete treponema pallidum. Ocular syphilis may present more commonly as interstitial keratitis or more commonly uveitis. Less commonly, it is also presented as cranial nerve palsies and optic neuropathy. About 4.3% of uveitis cases are diagnosed with syphilis. Syphilis is already popular as the great masquerade, and it can further perplex the ophthalmologist if the patient develops paradoxical worsening, and hence the study. So I'll be presenting a retrospective analysis of 3 patients with syphilis who presented with various forms of uveitis with or without systemic features, and how they develop paradoxical worsening and its management. The first patient is a 35-year-old female who was referred to us on post-operative day 1 post-cataract surgery. The patient's vision was counting fingers close to face. She had a hypopia on anterior uveitis, and clinical examination also revealed the presence of chancre-like lesions on the eyelids. There was also vitreous inflammation noted, but there were no fundal lesions in this case. So antechamber tap was done to rule out endophthalmitis, did not show any result on grams in culture, but PCR was positive for eubacterial genomes. Meanwhile, the VDR and TPHA came out to be positive. So she was diagnosed as a case of clinical worsening of pre-existing symptoms of syphilis and treated with antisyphilitic treatment along with systemic steroids, and showed good response. The second case was a 56-year-old female who was hypertensive and diabetic. Complaints of vision drop in the right eye since 20 days, also associated with headache. Left eye was normal, but the right eye showed hand movement, visual acuity. Intraocular pressures and anterior segment examination was normal. Fundus examination revealed dense vitritis with vitreous haze of grade 2, and a very faint retinochoroidal lesion could be seen, which was confirmed on the ultrasound. She was diagnosed as a case of posterior uveitis in the right eye. Laboratory investigations were done to rule out tuberculosis, sarcoidosis, syphilis, to rule out HIV, tuberculosis, sarcoidosis, and toxoplasmosis. And also AC-TAP was done, which was negative for TB, viral, panfungal, and toxoplasma genomes. Again, the VDRL and TPHA were positive in this patient. In view of history of headache and fundal lesions, CSF analysis was done, which was normal. She was started on treatment with procaine penicillin. However, she showed increased size of retinitis with suggestive of paradoxical worsening. Vitreous biopsy was repeated, again was negative for microorganisms and lymphoma. The syphilitic treatment was changed to IV benzathine penicillin, and systemic steroids was added. Here now she showed good response. However, the resolution occurred with lot of scarring. The third patient was a 34-year-old male patient, decreased vision in the right eye since 1 week and left eye, right eye since 1 year and left eye 1 week. She had a panuveitis with neovascular glaucoma in the right eye and anterior uveitis in the left eye. Fundus examination showed preretinal exudates suggestive of clinically syphilis, and it was confirmed on lab investigations with VDRL and TPHA both came positive. We ruled out an alternate diagnosis and treated with procaine penicillin and steroids along with glaucoma medications. Initially, there was good response to treatment with reducing vitritis and exudates. However, after 1 month, vision had dropped and there was increased diffuse vitritis and pre-retinal exudates suggestive of paradoxical worsening. We added doxycycline, which is a second-line drug, along with systemic steroids, and there was good response to treatment. And finally, it resolved with a chorioretinal atrophic patch and later developed posterior subcapsular cataract. So therapeutic paradox is known in syphilis, and this can result in extensive scar formation. After ruling out an alternate diagnosis, drug resistance and a poor compliance, we can diagnose as paradoxical worsening and treat them with steroids, and it will show good response.
These patients, exposure is there?
No, sir, there was no history of exposure, and only the first patient had a systemic lesion, a skin lesion. Otherwise, they did not have any history of exposure, no prior treatment with antiseptic treatment as well.
You screen the families?
Yes, sir, we did check for the spouse and other family members. Yes.
Regarding your first case, if you could just make it clear, this patient had this hypopyon on the first post-op day after cataract surgery.
Yes, the first patient was operated elsewhere and referred to our center because of counting finger vision on the first day. And when we actually checked for syphilis as a part of our routine examination as well. And at that time we got...
So how was this paradoxical worsening? The patient was already on treatment?
Yes, no.
Multiple myeloma is a plasma cell tumor characterized by excessive proliferation of plasma cells and increased production of immunoglobulins, and it usually affects patients in the age group of 50 to 70, and they usually have generalized weakness and body pain, and investigation will show that they have renal failure, hypercalcemia, and anemia as well. So here we have a 64-year-old male patient who presented to us with a gradually progressive defective vision in both eyes. He also had bone pains and generalized weakness. His vision in the right eye was 6/36, left eye 3/60, with a pseudophakia in the right eye and mature cataract in the left eye. Fundus examination of the right eye showed hyperemic disc and tortuous veins and a lot of hemorrhages, intraretinal hemorrhages, and serous retinal detachments seen inferiorly as well as at the macula. And these findings were confirmed in both eyes by the B-scan ultrasonograph. FFA showed tortuous veins, pinpoint leaks, block fluorescence because of the hemorrhage, and a silent macula because there was no leak at the macula. The investigations was significant in that there was anemia. ESR was grossly elevated at 120, and the serum creatinine was slightly elevated 1.2. And he also had clinically a soft tissue swelling at the nape of the neck, which was attached to the bone, and which showed osteolytic lesions in the skull X-ray. So with these findings, we thought of multiple myeloma, and we went ahead and did a serum protein electrophoresis, which showed the characteristic M band. He was referred for a bone marrow biopsy, which showed atypical plasma cells, which confirmed the diagnosis of multiple myeloma. He went in for treatment with the chemotherapy, and 4 months later, there was resolving serous detachments. So multiple myeloma is a hematological malignancy in which there is a proliferation of plasma cells and increased production of immunoglobulins, and this can cause hyperviscosity syndrome, which our patient had. He had hemorrhages and tortuous veins and microaneurysms. He also had, because of the deposition of immunoglobulins in the sub-RPE space, there was an osmotic gradient created, which caused accumulation of transudation of fluid in the subretinal space. So, in conclusion, it is important to consider multiple myeloma in patients presenting with serous detachment involving the macula, and early diagnosis and early chemotherapy can help save the life of the patient and also prevent vision loss due to damage to the RPE and the photoreceptors. Thank you.
What treatment you provided for this patient?
Yeah, he was actually referred to the physician, and he started on bortezomib and immunosuppressive cyclophosphamide and corticosteroids. He was also given injection alendronic acid for the osteoporosis.
This exudative detachment is resolved itself?
Yes, I was showed the V-scan picture. After 4 months of chemotherapy, there was resolving exudative detachment. This patient had exudative detachment both at the macula as well as inferiorly, and he had features of hyperviscosity retinopathy as well as gamma maculopathy. He had all the features.
Thank you.
Is this an isolated case, or have you seen other such cases?
We have
with antibodies.
Your title is a little misleading, epidemic retinitis. You should just have said rickettsial retinitis.
Yes,
Why?
ma'am. Actually, because Weil-Felix test is not a confirmatory test, because we are not isolating, so it is a presumed, I should have maybe said presumed rickettsial retinitis.
Yes. So because when I saw your topic, I was assuming that you would have included all the post-fever retinitis cases in this.
Yes,
That's
only
what.
the ones
Yeah, all viral retinitis cases, including COVID. So, but.